going to talk about anxiety, of course. And we're going to identify how avoidance behaviors contribute to worsening these anxiety symptoms in the young people we work with. I'm also going to explain the rationale for exposure-based interventions. And then we are going to go over common forms of exposure and also show how to apply a stepwise hierarchy to address anxiety in everyday clinical settings. Most kids with anxiety don't receive specialized CBT or cognitive behavioral therapy and exposure therapy. So my goal is here to equip you all with the ability to at least identify avoidance and start that bravery conversation, which we're going to talk more about today. So I won't spend a lot of time on, obviously, we know what anxiety is. It's future oriented. It tends to kind of be characterized by feelings of apprehension, tension, worry about the perceived threat. That's something that's not happened yet. And of course, unlike fear, which is a response to immediate present danger, anxiety kind of focuses on that what if threat. And I think most of you probably will see it in your patients or students and their physical symptoms. So muscle tension, increased heart rate, restlessness. And we're going to talk more about these physical symptoms because anxiety often looks like those somatic complaints, and sometimes the kiddo doesn't even know that they're anxious, but they're having these symptoms, and it's like resulting in the getting out of school behaviors or that school refusal that we see, which I'll talk more about as well. And then to differentiate that from a specific phobia, which is an intense, irrational, and persistent fear of a particular object, situation, or activity that actually poses little to no danger. And so we kind of commonly think about that as like arachnophobia or fear of like heights, storms, dogs, needle phobia, situational phobia, flying, elevators. But I think what we actually see more commonly, which we can use exposures for, is social phobia or social anxiety. So I'll be talking a lot about that today. And then in terms of how avoidance perpetuates anxiety, like I think that this is the biggest component of what I'm going to talk about today is having you all understand kind of how avoidance and when it deals with anxiety, how it basically is any action or behavior intended to prevent contact with an unpleasant stimuli. So that can be a situation, object, distressing thought, and then kind of understanding that paradox, which is while avoidance obviously gives you immediate relief from anxiety, it is considered maladaptive coping in that it prevents you from learning that the feared object or situation isn't actually dangerous, and then which reinforces that fear long term then. And again, this can be situational, like staying away from a place, school refusal, or it could be cognitive, so refusing to think about a topic. I hear a lot of parents tell me, "Oh, my kids just procrastinate. They don't like do their homework until the last minute." And yeah, that could be laziness, that could be ADHD symptoms, inability to focus, but it could be anxiety. Like they're like, I can't even think about this assignment because it just causes so much stress. So I'll just pretend like it doesn't exist. So we definitely see a lot of that. And so again, when a child avoids a scary thing, they feel that temporary relief, which reinforces the brain's danger signal, and this makes anxiety much worse. So we aren't trying to eliminate the feeling of anxiety. We are increasing the functional ability and the habituation to that feeling. So getting used to that feeling, letting your body know, your mind, your brain know that you can feel this distress and be okay and live to see another day. So that's kind of what the idea is of starting to kind of introduce the how avoidance plays a role in perpetuating anxiety. So here is an example of a common worksheet that we'll use with our patients. Kind of getting to understand that it's very natural to want to feel good always, but by avoiding these bad feelings, this will inevitably lead to more bad feelings in the long run. I just was working with a teen yesterday who told me that she can laugh about every hard thing in her life. She never cries, but then when something happens and it just escapes without her wanting it to, she'll cry and then her nose will bleed. And of course, I told her to definitely go see her primary care provider and make sure there's nothing else happening there. But I also think it is connected to anxiety, at least worsening that nosebleed, So we start talking about with our patients, our students, about avoidance strategies. Like, again, there's things that you might do to stay away from experiencing bad feelings. And then you can kind of look at that as avoiding situations like, not wanting to go to school, for example, like we talked about, avoiding intense emotions, not wanting to feel sad or angry. Avoiding physical sensations is a big one. So avoiding activities that might lead to headaches, stomach aches, shortness of breath, for example, and then avoiding thoughts. So like I said, trying not to think about things that have happened in the past. So trauma reminders are, again, going back to my example with procrastinating at school and not with schoolwork, it's because they may not want to think about those stressful thoughts about school. So then we have them list the positive consequences of avoiding these things and then the negative consequences. So the positive being, of course, feeling safe, not having to experience that distressing feeling. But then they start to realize there's negative consequences, which is missing out. Like I had a kiddo that had some separation anxiety and didn't go to sleepovers with her friends. And she was just really feeling bummed out by that. And so like that was enough for her to be like, okay, let me start figuring this out, Or like the teen I just mentioned with the nosebleeds, she has a lot of, past trauma that she's finally opening up about because she's realizing how it's still affecting her, even though she was not feeling the stress about thinking about it for so long, it was still coming up in other ways. So we use all of this to then start to talk about the rationale for exposure. So, after examining the positive and negative consequences of avoiding certain emotional experiences, we tell our patients, or they actually start to realize that excessive avoidance will actually keep them from living life to their fullest. And they realize that actually school gets harder when they don't go, or, they miss out on the social aspects of school or not going to sleepovers, or maybe they're not talking in class because they're nervous, but they realize now they can't order at a restaurant. So they're seeing how this is affecting them in bigger ways. And this is what starts to kind of get people open to the idea of exposures, like the idea of learning by doing. So, I start to say that this will help you experience the full range of emotion. Some teenagers I work with start to realize yeah, I avoid feeling bad. I would like to be able to feel a full range of emotion and know I can handle that. And so that's another way I kind of get people to buy into the exposure because, of course, first, people are like, no, I'm not going to do this thing I'm afraid of. Why would I do that? But like I said, I think by kind of explaining how avoidance prevents them from experiencing full range of emotion and living life to their fullest, they usually buy in eventually. And that's where you use the parent support too, and trying to teach them and educate them about how this is a useful practice. I let them know that we're not going to dive into the deep end. We're going to start with, less distressing situations first and build up to the harder ones. And that way, once you're able to manage the more easier situations and you feel stronger and stronger and have longer brave minutes, as we call them, then you're able to do the tougher things later. And, we let them know that we can do this in small ways, or you can work with a therapist who specializes this, who can really cater it to your preferences so that you feel like you're not being flooded, is what we call it, when you're exposed to a stimuli that's so distressing. And we'll talk more about that in a second. There are instances where that is clinically indicated, but in terms of these simple exposures, we don't want to override their nervous system. So we want to keep it kind of in small doses, the exposures. I am going to talk more about what that looks like next, but I do want to show this very brief video. It's 2 minutes. Just so you can hear someone else talk, but this is specifically about trauma and how prolonged exposure therapy helps actually even with trauma. And that's when we start thinking about referring someone to trauma-focused cognitive behavioral therapy. And while I won't go into detail about this, I just wanted you all to kind of know this exists if you didn't, so that you could possibly be talking to your patients or students about this as well.
If you have post-traumatic stress disorder or PTSD, it's common to feel like there are places or situations that are unsafe. It may seem like the best option is to avoid them, staying away from people or places that feel dangerous or reminders of a traumatic event. As a result, you may develop I can't rules. I can't leave the house at night. I can't trust anyone. I can't handle crowds. But these rules won't help you overcome PTSD. So how do you learn to say I can? Prolonged exposure, or PE, is a treatment for PTSD that helps you do safe things you've been avoiding. In PE, you and your therapist will practice exposure, meaning you'll work to approach things you've steered clear of since the event. You have to challenge your I can't rules to prove to yourself that you can. Remember when you were learning to swim or even drive a car? It was challenging at first, but got easier with practice. Exposure gets easier with time. With your therapist, you'll take steps to do the things that have been hard for you at your own pace. So if you're avoiding the grocery store, you might start by going when it isn't crowded, maybe bringing a family member along. You'll eventually practice going on your own, perhaps even during peak hours. With practice, you'll find that you can handle it. You'll also talk through the details of your traumatic event in a safe, gradual way with your therapist. Closing your eyes can help you concentrate. Retelling the event may sound like the last thing you want to do, but it helps with emotions like anger, guilt, and sadness. You'll listen to a recorded version at home too. After a few months, you'll find that you can talk about your trauma without feeling so overwhelmed. Prolonged exposure doesn't erase your trauma, but it can help you keep your traumatic experience from getting in the way of living your life. PE doesn't require you to take any medications. With your therapist's help, you'll follow a step-by-step program for about 3 months. Most people who complete PE show noticeable improvement in their symptoms, and many no longer have PTSD. Prolonged exposure works well for both men and women, and it's evidence-based, which means PE has been proven to work in multiple research studies. If prolonged exposure sounds like it could be right for you, talk to your doctor about finding a PE provider.
So that, again, is just kind of seeing how anything that we avoid that causes distress, if it's not actually dangerous in that moment, and of course that varies based on the situation, then that's something we can use exposures for. So I want to kind of distinguish so that in case you hear these words in the future, you're more aware that there's in vitro exposures, there's in vivo exposures, and then in the next couple slides, I'll talk about interoceptive exposures, which is facing physical sensations. But the in vitro exposures is kind of what you'll be doing, what I do in my office here. It's what you all could be doing if you want to work on some small scale exposures with your patients or students. So these are, they're imaginal. So we're having the young person think about the thing that causes distress, not actually, doing anything or interacting with the thing, but just more imaginal, visual representation. There's some level of realism, but it's a very, very controlled environment. And then we give it to the parents, typically when you're working with kids, to take these exposures out into the real world, outside of the office. Sometimes we can do things around the area here. We're very, an exposure-based clinic here. So we'll have the patients check themselves in at the front desk, or, we'll walk go ride the elevator with the parents' consent. We'll go outside. We've even walked down to the Dunkin' Donuts next door to have them order with us. So it's still controlled, but we're getting that more level of the realism, But then I have the parents take over and take it home in the less controlled environment, like either riding in the car or if they're afraid of after a car accident or something. So that's why I want you all to know that because we empower the parent to become the therapist with their children, you all too can do some level of exposures, I think, with the students you work with and the patients you work with. I know there's a mix of providers here today. And while you may not be able to do the full exposure therapy in your practice, I think when I'm starting to talk next about the hierarchies and creating hierarchies and how to do that, I think of it as you at the very least need to be able to educate families on how avoidance reinforces anxiety and how exposures help. And then for more mild cases where you don't feel like there is a referral available, or maybe the wait lists are long, I think you can make a simple plan for how exposures with that parent and the child they can do together at school or at home, or maybe they'll come back to the next visit and have done some exposures and report back to you. And then, of course, we'll talk about if they get how to know if they're receiving that exposure-based therapy. If they are in therapy and they still have issues with avoidance, then you can talk with the parent and the patient about, well, are they doing exposures with you? And that might be an indication of, well, actually, it sounds like they're not. So let's find you a good referral. And that's probably when then you can call us too to help you find those referrals. So I want you to keep that in mind as I'm going through these next slides. So exposure hierarchies. Basically this could be considered kind of explaining it as building a bravery menu. We start with the things that make the child least worried, and we move up to the harder and the hardest things then. We like to use this feeling thermometer. I'll show you better examples of that in a moment, but because we want to start with the lower levels of distress. How much anxiety or fear do you have? Not at all is the bottom level. So we want to start with 1s and 2 situations. And again, I'll show you some examples in a moment, but we kind of list it using different worksheets like this. So for example, like with dog phobia, we would start with like things that make them least worried about dogs, like maybe showing them a photo, then a video, then looking at a dog through a window, and then eventually getting closer and closer to a safe dog would be an example of how to use this. Here is another example. And then this is just another way you can like sort the situations that cause anxiety to most tolerable, moderately tolerable, and then least tolerable. And this feeling thermometer, this fear thermometer, I like because it really does a good job of showing the subjective. So we call it the subjective units of distress, or the SUDS. And this is a great tool that you all can be using as a metric, even in a 15-minute well-child visit or in a school check-in, to assess the level of distress where they're at now versus last visit, and to review any positive coping they were able to do to help manage these feelings of distress if they tried harder things. And I think what's really important to note here is like the halfway point. This is hard, but I'm in control. That's, like I said, we don't want to flood our students, our patients. We want them to be able to keep moving up the fear ladder in a way that keeps their distress at a level 5 or below, is what I like to say. Because that reminds them that it's like not to the point of like severe nervous system dysregulation where you can't cope, you can't use rational thought statements anymore. So we wanted to be, moving up and habituating them to an extent so they can keep doing harder things, but staying at that level of around 5 or so. Here's one more example. In my practice, I tend to use a lot of the idea of the fear ladder. So I like the idea of being able to climb up and doing harder things as you go higher on the rungs. And that's a really nice way to think about it. And here's another example of a fearmometer, they call it, which I think is cute. And, different ways to help kids understand what their level of distress is, their SUDS, piece of cake, all the way to out of control, ballistic. I take it a step further when I'm doing the feeling thermometer with my patients, because I really want them to understand how their body feels and like what they're thinking when they're feeling this like increasing distress. And you'll see that I don't use worksheets. These are things you can just have a piece of paper and a pen and be able to do quickly. Like this probably took 5 minutes. This kiddo was going to do a caroling event, and she was afraid that she was going to get the mic and that she would forget her lines, and that she would be embarrassed, and that no one would ever talk to her again. So those were her negative thoughts that we were working on as well in conjunction. But we were able to use that example to kind of rate her fear level. And we threw in some other examples of when she's anxious to kind of understand what's happening with her body when she's feeling increasing levels of distress. So, when she was thinking about the caroling event that was 2 weeks in advance, she wasn't worried about it at all because she was using a safety behavior by avoiding thinking about it. And then as they got closer, maybe like the day before, her anxiety went up to a distress level of 5. And then we use another example of how when she's anxious, her heart rate will start beating fast because she had recently went to her primary care doctor's office, and they had, measured her heart rate, and it just stayed around 122 beats per second or per minute, because she was so anxious, not only about going to the doctor's office, but also about her heart beating fast, which then made her palms sweat because she thought something was wrong with her. And then she kind of had that fear sensation of like the idea of fear itself, and like that she must be wrong. So her fear even, got bigger. So we said that her stress at that point was like at a 6.5, 7. And so I also use in these fear thermometers like ways to cope. And so as you notice, as we go up, we use coping thoughts for levels like 1 to 5, because you're still able to kind of rationalize. You're not cut off from that logical frontal lobe piece. But then as you get more distressed and more dysregulated, you're working out of the amygdala. You're not able to think as clearly. So we do action-based things. We do she's on her way. She's thinking ahead. She's on her way to the caroling event. She's really anxious. Her heart's beating fast. Her palms are sweaty. So she's not going to be like, I'm okay. She's going to roll down the window, get some fresh air, put a little chocolate in her mouth, do a mindful chocolate experiment so she can just ground herself and kind of bring it back down to a 5. In this situation, her anticipatory anxiety was far greater than the event itself, which is what we see is typically the case. Another thing I want to add for this is that, we have to kind of encourage and empower our parents to not to jump in and rescue their children and to overly reassure them, because that acts as like a safety behavior too. And first of all, in this situation, this patient was asking mom repeatedly, like, well, what's going to happen? Like, when is it going to start? And will I remember forget my lines? And like, your parent, as a parent, your inclination is to want to support your child and to like make them feel better, so you're reassuring them. But this parent was kind of getting frustrated because she was answering the same questions over and over. So we kind of tell parents, like, you have to, like, that's an exposure itself, is removing that reassurance, because it helps them feel that distress, and then they get used to the feeling of distress, and their parents not reinforcing the danger by trying to rescue them. Here's another quick example of a child I worked with who had some fear of the dark, and how she was able to kind of feel her heart beating faster when her parent was farther away. It was the middle of the night. It would get worse. Again, so these are just quick examples of how to kind of do your feeling thermometers with your students and patients, and just kind of help them understand where they're at what point, and how to keep it at a 5 and below. And now I want to show you more of the fear letters I've made with different individuals. This one was for a kiddo who had like some selective mutism, social anxiety. So we ranked different situations where she had to talk, because she definitely would not talk in clinic. She would, use yes, no, thumbs up, thumbs down when talking to me. So we made a fear ladder for her to kind of overcome her social anxiety. And it started with just talking to people in the family, doing these like, kind of like, okay, this is a purposeful situation in the kitchen tonight. We're going to just have you say some words, talk more to us as a family. That was a 1.5 for her in terms of SUDS. And then it was me doing telehealth with me, and just saying yes or no, saying yes or no to me in person, talking to full sentences with me on video, and then talking to teachers. We also have kids, like I say, check in at the front desk here. We try to do a lot of those in vitro exposures kind of in the controlled setting here, which can mimic a lot of what they would feel at school when she would try it at school. And now she's talking all the time, and it's great. Another thing we've done sometimes with kiddos is it's not the talking that scares them anymore. It's the fear of being wrong. So sometimes I had one patient who would ask for the wrong change, like at Subway, and like give a 5 and they were supposed to get $3 back, ask for $4 back, knowing that like, or ask for $2 back, or another amount. And so knowing that they would correct her, and her parent was there, and obviously they would have like made sure it was right at the end, but they wanted her to feel that feeling of getting something wrong, and then still knowing you'd be okay afterwards. Another quick example of just another teenager I work with who has some fear talking in class, and how we really distilled it down as she got better at doing it. It became more nuanced, like a bigger small group versus a pair, versus reporting back first in the class versus later on in the class. So we just really start looking at ways she can start making things tougher for her, so she can get better acclimated to that feeling of distress. And so then after the exposures, you want to do a reflection. You want to check in to see, like, what did you do during the exposure? What were your worried thoughts? What were your calming thoughts? And then we always like to use positive reinforcement. You did a hard thing. You were brave. What reward did you get? What did you learn? And, most of the time, like I said, we'll see that the child had more anticipatory anxiety or worry about the thing than the thing itself. The thing itself usually is not scary, and they start to learn that, oh, my worry about the thing is definitely far worse than the thing itself. And that's really what we want them to start seeing. So this is a nice way to start doing those reflections. There's another nice worksheet we use to start plotting out their amount of brave minutes doing the exposures. And what they'll see over time, of course, is that when they start off, their distress fear rating is like an 8, but as they go down, the wave goes down. As they get longer in their brave minutes, their distress goes down, and the wave plateaus. And it's a nice visual representation of how this exposure intervention really does help their anxiety. So quickly, I want to just talk about interoceptive exposure. We think of interoceptive exposure in terms of mainly, I think, in panic disorder, but we have a lot of kiddos who have some fears of getting sick. We have a lot of kiddos who have fears of vomiting, for example, which, brace yourself, we are going to talk more about coming up next. And so we had one patient who was so worried he'd get sick at school, embarrass himself, like that he would throw up at school, that he would stay home. His stomach was slightly like uneasy. And then as we kind of helped him move through that, he would do these safety behaviors, which was kind of using a stethoscope to, hear the gurgling in his stomach. And if it was less gurgly, he'd be like, okay, I'm good. I can go to school. This is also a kiddo who asked for a lot of reassurance from mom, like, will I get sick? Will I get sick? So we had to help mom understand it's okay to kind of ask him, like, what do you think? What did we talk about with this before? Kind of giving it back to him to know that he can kind of manage that on his own. So the idea of interoceptive exposure is that it treats the fear itself, so those physical symptoms that are inside your body. So it's like the idea is like you're not afraid of the elevator, you're afraid of your racing heart because your brain misinterprets that information and thinks the physical sensation is actually a sign of impending catastrophe. Like, my heart's racing so fast, I'm gonna have a heart attack, I'm gonna die. And that's kind of where your brain goes. So if we help them kind of do this interoceptive exposure in the clinical setting by like spinning in the chair, holding your breath, going up the stairs, by intentionally inducing these different scenarios, we reteach their nervous system two things. One, that it may be unpleasant, this feeling, but it's not dangerous. And two, these feelings will naturally resolve without you having to use your safety behaviors like the stethoscope or having to escape the situation. So that's a really important message, I think, to share with your patients and students. So quickly, I'm going to go through an example of creating a hierarchy for emetophobia, which is the fear of vomiting. So, just so you know, there's going to be nothing bad, but I just wanted to give you that trigger warning. Recent research, a study in the Journal of Anxiety Disorders showed that up to 9% of school-age children experience vomit phobia. But as clinicians, I think I've read and talked to my colleagues, myself included, we experience up to 20% of our patients, I think, who come in who have some level of vomit phobia symptoms that affect their ability to ride on trains, create school refusal. So, we really do take this seriously, and we have a huge training in our clinic every year about exposures for vomit phobia. I think that the main idea of this is that kids with this will often avoid doctor's offices, transportation, schools. They'll avoid people who are ill. Maybe they'll hold their breath. Maybe they'll excessively wash their hands. They're maybe always sipping water. They're checking their stomach with a stethoscope, doing things, seeking reassurance, like I mentioned. So that's why it's important that we intervene with this. So what does that look like? Well, we start with the in vitro. Some kids are averse to even V words because it reminds them too much of vomit. And so we'll start with just thinking about the word, thinking about V, thinking about any V word. And then we'll go up to like words and phrases, different words that mean that. And then we'll progress to sentences, things like that. We'll have them read a paragraph. We'll read them a paragraph with the word in it, or with a situation where someone is throwing up. And then we will progress to cartoons of someone throwing up, things like that. And then it's true, we do go to actual photos. So I won't spend a lot of time on that one, but that, it's really important because while no one wants to throw up, mostly it's good and you'll feel better, and your anxiety about throwing up is limiting you. And so let's get you okay with the idea that it might happen and just be done with it. So that's why we do this. We have a recipe. We make vomit in our clinic, and it's chunky beef stew, mayo, Cheese Whiz, Mountain Dew, microwave it to create this stronger smell. We actually take our trainees when we're practicing this to the bathroom to practice, dumping it in the toilet. And then you can add sounds and videos. You can get you can use your senses, and some people need to touch it and do things like that. Every year we have many trainees who cannot do this, And I just remind them, like, you're a grown up, and imagine how hard this is for a kid, and how how good it will be if they're able to master this. Everyone likes feeling like they can master something, you know. Um, this is a live photo of some I created this very year in our clinic. So there you go. Um, Finally, some other thoughts about working with vomit phobia in particular. You have to just watch out for those sneaky avoidance behaviors. Again, like carrying a water bottle or sitting near an exit. So for exposures to really work, these crutches must eventually be removed. So there's different ways we can keep tackling this, but like I said, I won't spend too much time on that since we're running out of time. And the key takeaways, again, for you all is that anxiety is maintained by avoidance. Every time a child avoids a feared situation, the danger signal in the brain is reinforced. So, and exposures are the antidote. We aren't just talking about fears, we are practicing being brave in small, manageable steps. So, that think about the fear ladder. And like the main takeaways for you all, I think, is to identify the avoidance, of course. Be like, I see they're not doing this thing. That reminds me, exposure therapy. First, validate and normalize. It's okay to feel scared, but we don't have to let the fear boss us around. Identify the goal. Help the family pick one small, brave practice to try before the next follow-up. Introduce the fear ladder concept to the family. And then you can use the fear thermometer to gauge severity and to gauge their progress. And then finally, call us for referral if you feel like this is like more complex or that they really need some more specialized care into addressing these avoidance behaviors. We'll vet resources for you and find a provider who can do that exposure therapy. All right, and that is a very quick overview, but I think hopefully it gets you all starting to think about how you can either use this or refer some patients or students for some additional care. Does anyone have, and there's a survey here that we would like you all to do too, to give feedback on this webinar and to give us some thoughts about future webinars too. But I'm happy to take any questions now.